some examples of how our community can develop strategies for addressing equity, diversity, and inclusion. And while the perspectives that I will be sharing with you will reflect some of the OBGYN physician experience, I hope we will be able to share some of your perspectives as nursing colleagues, as our professional communities rely on each other for collaboration. From my perspective, understanding what equity, diversity, and inclusion mean, other than through personal lived experience, has involved much learning and education. And while interpretations may differ, I would like to start with a few definitions, sharing those with you so that we can feel like we're starting from the same place.
Hi, Dr. Maxwell. Sorry, someone said that the slides aren't changing.
Okay. I see, actually, that is true. Okay. I'll try that one more time. Thank you for that. I think that looks like it's working. How does that look to you, Emily? Yeah? Okay, thank you so much. Okay. So sometimes I think it is easiest to define equity by what it is not. Equality implies a state of sameness, and it's related to the idea that if one of us, each one of us works hard enough and long enough, that we will be able to achieve our desired goals. We know that this is unlikely to exist in our world since access and opportunity may be limited for individuals and for certain groups. The groups we commonly think of when we recognize social inequality are historically characterized by race, disability, gender, sexual orientation, among others. Okay. Thus, an essential element in achieving equity involves recognizing those characteristics, those entities which may differentiate one group from the next. We have evidence to show that equity drives innovation when done correctly, given the diverse voices that then come to the table. The recognition of those differences which may contribute to inequality are used to achieve fairness, impartiality, and the level playing field as illustrated by this image. We are mindful that using such images can sometimes be problematic, as some could interpret these images as implying an intrinsic inferiority in one group or another, or in a person. As we live in a diverse society, it is important that our reproductive health care force recognizes and reflects this diversity. For diversity to be meaningful, it needs to have more than simple representation. Diversity embodies mindfulness of our differences and allows for inclusion. So diversity and inclusion rely on each other. Inclusion is the full integration of diversity. The climate and culture of the organization nurture the diversity of its individuals through mentorship, professional development, as we're participating in this evening, education, policy, and practice. For important historical reasons that we won't be able to cover in detail today, we will need to accept and acknowledge that there are many people who seek equity, and these are most often people who we refer to as underrepresented. That means, for example, in a city such as Toronto, people of racial backgrounds are not proportionately represented in our healthcare workforce, more specifically amongst physicians. I believe this may be different amongst nursing professionals, but maybe we can discuss that a bit later. In our GTA region, this includes Indigenous people, Black people, and Filipino people in terms of race. Other groups that lack representation include members of differently abled groups, members of our LGBTQ2S communities, and those belonging to disadvantaged socioeconomic groups. Sometimes an individual can belong to more than one of these groups and may experience layered or complex barriers to success in their professional career or in access to healthcare. This is called intersectionality. For example, racial minority men may experience discrimination that would not be faced by non-minority males or even women of the same background. This is because groups often experience distinctive forms of stereotyping or barriers based on a combination of race and gender. Similarly, persons with disabilities may experience particular barriers when they identify by another affinity, such as gender or race. Regardless of how we identify ourselves, we all possess biases. And the unconscious or implicit ones are especially challenging in our society and in healthcare. We judge people based on their appearance, whether they look like us, if we have a negative assumption about them or their background, and so on. Biases influence all aspects of our professional lives, workplaces, search committees, and board leadership structures, among other areas. In a day-to-day context, unconscious biases are insidious because they seem more prevalent, or they appear more prevalent when we are tired, stressed, or multitasking, which I'm pretty sure we all do lots of. Unconscious bias can lead to acts of microaggression. So those are the slights or the insults we utter without realizing how they are offensive. In contrast to macroaggressions, a verbalized racial or ethnic slur, for example, the microaggression is not so easily identified. Here are a few examples taken from a table that was included in our university department guideline for equity in continuing medical education courses. And so this was developed by me and colleagues from our department. So if we look at questions like, where are you from? Or where were you born? And you may have experienced this in your professional lives as well. Those kinds of sentences or questions send the message that you are not Canadian or that you don't belong. And this is sometimes called othering. Statements like, everyone can succeed in this society if they work hard enough, belies the myth of meritocracy, since this statement can only work if we are starting the journey from an equitable place. Systemic and environmental examples include things you may have noticed in courses, or maybe if you've attended lectures or other panel discussions in the past. So for example, in a course, all images and speakers may belong to the dominant social group. And while not intentional, avoiding such exclusion does require intentional planning. To overcome aggressions, microaggressions, macroaggressions, we need to be allies to each other. Being an ally requires awareness and courage. So when you observe the transgression, you acknowledge your awareness, you step out of your comfort zone, and you take an active role in pointing out the problem. The ally will take things one step further, involving themselves to be part of an ongoing solution to these problems, and thus becomes an advocate. So let's talk about where we are now in OBGYN and obstetrics and gynecology, and we'll start with our patients and families first. I believe the most obvious and current example of health disparity is the impact of COVID-19 on the groups identified by race. So this summer, Toronto Public Health released several months worth of data, which is shown here, illustrating the disproportionate impact of COVID-19 on Black, Indo-Caribbean, and Southeast Asian people. The graph on the left compares each group's share of COVID-19 cases compared to their share of the population. So if we look, for example, 21% of COVID-19 cases have occurred in Black people, while they represent 9% of the population. If we look at the right side of the screen, we also know that lower income residents have been hit harder by the pandemic. As we talk about these health and social disparities, we are mindful that it is not race or ethnicity per se that predisposes to poor health outcomes, but rather it is the systemic and historical problems that, as well as discrimination against these groups. We can draw from a number of examples in the reproductive literature to understand some of our specialty-specific challenges. So for example, a paper by Dr. Kiran and colleagues examined cancer screening in transgender adults. In Canada, transgender adults are less likely to receive gynecologic cancer screening as compared to cisgendered adults. In this study, which examined the presentation and quality of life in people with fibroids, Dr. Murji, who's a physician who works at our hospital, and colleagues noted that postmenopausal Black people and East Asian people have increased burden of disease from fibroids compared to their white counterparts. In this study, as another example, by Dr. Brown and colleagues, higher than expected rates of pregnancy occurred in people with disabilities, and this was most notable in the adolescent population. Identified barriers to their accessing reproductive healthcare services included healthcare provider factors, such as reluctance or perhaps discomfort with these types of discussions, as well as general accessibility in the healthcare setting. I will note that there are similar challenges, related to provider factors and accessibility as are faced by people with obesity, which is a topic and area of my own clinical interest. So we'll shift a little bit to our medical learners. I do realize that the process for nursing learners may be a little different from ours, but I think that there are probably some shared experiences and themes in the educational journey that I think will resonate. So what can our learners, our medical learners, expect to experience during their years of OBGYN residency? So while we may lack specific public information regarding OBGYN residencies in Canada, it is possible to learn how other specialties experience issues of equity and professionalism. So this is an important study, I think, in this area. So general surgery, this is a study about general surgery. The culture in general surgery may in fact differ from OBGYN culture in many ways, but we do both share some surgical and team characteristics, especially when it comes to labor and delivery and in the main operating room. So I believe that this study is quite striking. And there's some lessons that we can learn from it. So in 2019, this study, Discrimination, Abuse, Harassment, and Burnout in Surgical Residency Training, was published in the New England Journal. Dr. Hu and colleagues conducted a survey study for accredited surgical programs in the United States with an impressive response rate of 99%. Among the over 7,000 residents from all 262 surgical residency programs, this group found that 32% reported discrimination based on self-identified gender, 16% reported racial discrimination, 7% reported discrimination based on pregnancy or childcare status, which is interesting. 30% reported verbal or emotional abuse, and 2% reported physical abuse. The rates of all mistreatment measures were higher among women. Patients and families were the most frequent source of gender discrimination, as reported by over 40% of the residents, and racial discrimination, whereas attending surgeons, so the staff physicians, were the most frequent sources of sexual harassment and abuse. Both self-identified gender groups experienced sexual harassment at a rate of 10% overall. And most worrisome, close to 40% overall met criteria for burnout, and 5% had actually contemplated thoughts of self-harm. Given the scope of these breaches in professionalism, as well as the direct impact on the trainee's health, widespread awareness and training will be needed to counter these events. And I think that having similar data for our specialty, specific to our specialty, would be one place to start. And I think you'll find in these conversations that data is a recurring theme in the equity journey. Shifting our focus to ourselves as professionals, we do recognize the diversity of our specialty, which includes many types of providers, including nurses, midwives, family doctors, and of course, members of our communities, such as community leaders and doulas. What does all this mean for a specialty that is focused on issues of women and people's reproductive health? I believe the demographics for nursing are a little bit different than that of the physicians. but perhaps you can help educate me as well afterwards. As doctors, we are now a specialty dominated by women, as we can see from this data released by the Canadian Medical Association, the CMA. From 2000 to 2019, the percentage of female physicians has increased impressively from 30 to 61%. I reflect on how this will impact our specialty going forward. Will we be representative if one sex is eventually excluded? How will the training of males be impacted by diminished numbers and potentially opportunities to learn reproductive health care? From the perspective of female physicians, however, how has this demographic shift impacted professional life? According to the CMA, currently 54% of physicians in Canada are under the age of 40 are women, and it is projected that the physician pool will be evenly split among women and men by 2030. While the representation of women and other marginalized groups within the medical profession is improving, discrimination and bias at the individual and systemic levels continues to create barriers to advancement, health, and livelihood. Experiences of discrimination in the workplace are common for physicians. In one study, 51% of women, and also interestingly, 31% of men reported experiencing workplace discrimination. In a recent study investigating a form of implicit bias in speaker introductions during grand rounds, 69% of women were introduced by their formal title compared to 79% of men. And this disparity was exaggerated when men were giving the introductions. This overall situation, by the way, contributes to pay inequity experienced by women physicians who on average earn less annually in primary care and specialties than their male counterparts. Moving along and thinking a little bit more about other aspects of diversity in the medical profession, I draw your attention to this study by Dr. Walji. Dr. Walji wrote an article for the CMAJ, Canadian Medical Association Journal, about diversity in medical education, the data drought, and socioeconomic barriers. While we have some data regarding our physician workforce in terms of self-identified gender, and until recently, I should say, Canada had not documented diversity. The National Physician Survey began to collect data in 2007 with a response rate of about 24%. By 2030, about 30% of Canadians will be non-white. In cities such as Toronto and Vancouver, that proportion is estimated to reach 60%. Evidence tells us that physicians from underrepresented visible minority groups increase access to care directly because they are more likely to practice in medically underserved areas and populations. The good news is that in Canada, groups including South, Southeast, and East Asian people are increasingly well represented in our medical schools, so that is some progress. The number of medical students who identify as Indigenous has increased from 1.6% in 2007 to 4.4% in 2012. However, only 2.9% of all medical students in 2012 reported identifying as African or Caribbean, which compares poorly with 4.2% of the general population and 5.8% in the province of Ontario. In 2012, 56% of Canadian households reported an income of less than $60,000 per year, yet only 23% of medical students came from families in that income category. Whereas 23% of Canadian households earn more than $100,000 annually, 52% of medical students came from families in that higher income group. Dr. Walji thoughtfully notes that, and I quote, "We celebrate our multicultural identity and our diversity, and perhaps we like to think that notable differences do not define who we choose as our friends or our future medical professionals. Our aversion to gathering data," this is in Canada, "on physician diversity suggests this sentiment runs deep. Yet, our unwillingness to talk about race, ethnicity, and social class does not mean that the system treats everyone equally. Racial, ethnic, and socioeconomic factors do influence who is admitted to medical school. So once our medical students have graduated and they become doctors, how is their experience in practice? we still have a bit of a data drought, but we are getting some new data on the experience of physicians, of racialized physicians in particular, that are currently in practice. Dr. Mapalriwa and colleagues reported on the experience of Black physicians in Ontario in 2019. Participants reported positive experiences of collegiality with Black colleagues and strong bonds with Black patients. Negative discrimination experiences included differential treatment and racism from peers, superiors, and patients. Participants reported race as a major factor in their selection of practice location, interestingly, more so than selection of career. Participants also expressed a lack of mentorship, and there was a strong call for increased mentorship from mentors of similar ethno-racial backgrounds. It may be helpful to summarize the challenges in our medical profession into broader themes. Dr. Asola and colleagues analyzed the major factors impeding an inclusive work and learning environment in this GEM article from 2018. They completed a qualitative analysis of responses from healthcare providers. These responses requested stories reflecting on inclusion or lack thereof within the participants' work environment. The analysis of the narratives revealed 6 broad factors referred to as the taxonomy that affected inclusion within healthcare organizations. And they are as follows. Number 1, the presence of discrimination, the silent witness effect. You see the inequity or the injustice, but you don't speak up. 3, the interplay of hierarchy, recognition, and civility. Next, the effectiveness of organizational leadership and mentors. The next, support for work-life balance, and then finally, perceptions of exclusion from inclusion efforts. So what is the way forward? Dr. Kang and colleagues reported in The Lancet in 2019 that a number of myths perpetuate factors mentioned in the previous slide. These myths include not recognizing our own biases, assuming that you can change the way people think, and that there is a supply problem or a pipeline problem, as it's sometimes called. And then finally, of course, the myth of meritocracy. The solutions generally point to success when change is implemented at an organizational level through metrics, programs, guidelines, and leadership. For example, data collection. You can have a pre and post intervention study. You can try to create a culture in which people feel personally responsible for change. So for example, people are assigned mentees to mentor through mentorship programs. Implementation of behavioral guidelines and action plans so that people don't have to sort of make their own choices about how to handle particular situations because you have a guideline in place. You can change institutional norms, and this is where leaders become important because they have to lead by example. You can create organizational accountability for change and include equity, diversity, and inclusion in your framework and or in your terms of reference of your organization. So let's examine some effective examples of implementation in the context of an academic department of OBGYN, which of course includes physicians, but also learners, nurses, and all of the other health professionals involved in that care. So Dr. Imeje and colleagues reported on their OBGYN departmental approach to diversity, inclusion, and equity in the American Journal of OBGYN in 2020. Over a 4-year period, faculty and staff participated in town hall meetings, focus group discussions, surveys, and community building activities to foster stakeholder engagement. They concluded that meaningful engagement with a continued focus on recruitment, selection, retention, and development of faculty and staff from underrepresented groups may result in sustained change and impact in OBGYN. So how did they do this? If we take a closer look at this example, we can see the implementation put into action. They structured all of their departmental grand rounds to focus on topics such as shown on the right. So you can see they had sessions on transgender care, unconscious bias, and so on. They had multi-site heritage festivals in addition to workplace civility, lunch and learn events. I guess we can't really do those during the pandemic, but I guess if we can ever resume them, those would be potential things for us to do in our hospital settings. They created a curriculum for care for transgendered people. They focused on centering pregnancy models of care, so focused on the community as the starting point. And then they looked at their recruitment of OBGYN residents and so that was changed to promote a more holistic view of the applicant. Interviewers were masked to the cognitive characteristics of the candidates, such as the board scores or USMLE scores, clerkship grades, and so on, to decrease the halo effect, to reduce implicit bias. University of Toronto, so focusing on ourselves now, University of Toronto has taken several important foundational steps to improve equity in the Faculty of Medicine. As part of the Faculty of Medicine strategic plan, Excellence Through Equity, this plan has driven many enhancements to our programs and our processes within the university. The Office of Inclusion and Diversity was thus established and has many resources available to clinicians, instructors, as well as learners. In response to the Truth and Reconciliation Commission of Canada's call to action, some medical schools, like University of Toronto's Temerty Faculty of Medicine, have developed a program to promote and foster Indigenous health and medical education. Some examples of how this can be implemented include establishing spaces where Indigenous learners, faculty, and staff can come together, socialize, and study in partnership with the affiliated hospital, recruiting Indigenous faculty and staff to lead all aspects of Indigenous medical education, establishing an elder in residence role for the Faculty of Medicine to support learners faculty-wide. And in keeping with the Faculty of Medicine's values, such teaching could be incorporated into many teaching programs, including nursing programs, including residency programs. So what I'm describing right now is focused on the undergraduate learners, but I think that this could be easily applied at other levels. I shouldn't say easily applied, but with effort and organization, I think it could be applied. The Faculty of Medicine, University of Toronto, has also adopted a Black health curriculum, which provides health education regarding the Black people of Canada, about Black Canadian health, and the inequities due to systemic racism. And so these initiatives were instituted at a really important inflection point at the University of Toronto Faculty of Medicine, by the way, because it was right at the time where the medical school, I believe, was in the news. So you may have seen these articles. And at the time in 2016, the news was that there was only one Black student in the class of 259 medical students. In response, U of T then established the Office of Inclusion and Diversity, which I just referred to, and set up a program to encourage and support Black student applicants. So in 2020, the university was really proud to announce that 24 Black students were accepted. And there are similar programs to support Indigenous learners, medical students at University of Toronto. At our hospital, so my base hospital is Sinai Health in Toronto. We have taken a number of important steps to create a foundation for equity, diversity, and inclusion in our hospital department of OBGYN. So most recently, we have formed a diversity, equity, and inclusion working group in our Women and Infants program at Sinai. That's the name of the program, and which I am so proud to co-chair with our nursing unit administrator, Catherine Britton. We have a hospital-wide steering committee as well, working to dismantle systemic bias and racism. So there is work going on hospital-wide. At the provincial level, I have co-chaired recently a task force that was aimed at creating provincial guidelines for pregnancy care during the pandemic, COVID-19. As a consequence of developing these guidelines, the health equity issues became a major part of the conversation. For those of us on the task force, we were really challenged to find validated and current tools to inform our work from an equity perspective, and in particular when addressing the pandemic effects on vulnerable populations, including ourselves and including our patients. So, for example, how do we address the safety of our essential healthcare workers of Asian descent who face discrimination in the wake of the pandemic? This was a big issue during the first wave of the pandemic. How can we mandate social distancing when populations at risk are living in crowded conditions? How can we promote virtual care when people may not have cellular reception or access to the technology? So in the introduction to the guideline, you will find this citation, which focuses on Indigenous health from an Indigenous perspective. I'm going to read this to you as an ally, as this passage actually comes from an Indigenous voice. So here's the quote. It has been said that for Indigenous populations, we are already walking in a pandemic. Our communities are at the front line of an inequitable system. The trauma experienced within the healthcare system that is systematically biased and racist is real for us and for our clients. It's a system that leaves us with limited supplies, inadequate or no clinical space, and is painfully slow to respond to our needs. COVID-19 is a new and added layer to this. So this work within the task force has been part of the motivation to create a health equity strategy at the provincial level to help inform this type of work moving forward. And I'm really proud to be part of this important change in our provision of maternal and child health at a systems level within the province. So I'm going to conclude there and leave you with what I think are some of the important takeaway points. So first of all, equity, diversity, and inclusion are central to the well-being of our patients and our families. Equity, diversity, inclusion are central to the well-being of our colleagues and ourselves as healthcare providers. There are many approaches that can affect the change and improve our equity strategies, but rather than trying to change only one individual at a time, I think organizational change is the key. So I will stop there, and I would be very happy to have a conversation, answer questions, and I guess I will turn it over to Emily at this point.
Thank you, Dr. Maxwell, for a very comprehensive presentation and lots of good information and key points for us all to take to our different disciplines and areas. So I now open the floor to everyone for a little Q&A session. Feel free to type it in the Q&A, or I can also unmute you if you'd like to speak. Just let me know by raising your hand or specifying in the Q&A chat. Okay. So Lori, you should be unmuted now if you want to speak.
Hi, can you hear me?
Yep.
Hi, it's Lori Webel-Edgar. Hi, Dr. Maxwell. Thank you for your presentation. I'm so excited to see this conversation continuing. Your presentation was fabulous. I'm wondering about if you're aware of any health human resource strategies for obstetrical care in Canada, and if there is an equity lens being applied to that work anywhere?
So first of all, thank you for the question, and hello. Nice to hear from you. In terms of human resources, so I think that if we look at I guess from the physician perspective, the hiring and so on obviously is based at hospitals, and I think that hospital approach to equity, diversity, inclusion is pretty varied, and it depends how far along, I guess, in the process or in the discussion each institution has come. At a national level, the body or the organization that oversees our profession would be the SOGC, so the Society for Obstetrics and Gynecologists of Canada, Obstetricians and Gynecologists of Canada, I should say. And until recently, there wasn't really a coordinated effort to look at equity initiatives within the professional group. There was obviously some important focus on issues like global health and access to contraception, and also an Indigenous health strategy as it related to reproductive health, but not a human resources per se type of approach. So I have been in conversations with the SOGC leadership looking at its committee composition, how committees are struck, how board representation is decided, and all of those issues are now being examined and looked at the national level. So there is a working group for diversity, equity, inclusion at the national level to help start to address those issues. It's all pretty new though, like this is all within, I guess, the last year or the last few months. So I guess we're really at the starting stages of this work at a national level. At a provincial level, I think other than organizations such as the Provincial Council for Maternal and Child Health, which are really looking more at sort of systems and patient issues, I'm not sure that it's as much of a human resources focus as I think, which is I think related to the question that you've posed. So, you know, I think that there is, we probably need sort of a gap analysis or assessment for where we are in terms of equity and our human resources systems wide at this point. I hope that answered your question.
Yeah, thank you.
Welcome.
So in the chat, we do have a question from Lindsay. Can you speak to childbearing morbidity and mortality rate in transgender individuals compared to cis individuals?
Thank you very much for that question, Lindsay. I didn't include slides on that tonight, but there is definitely emerging literature in that area. I think that the whole topic of reproductive care, so obstetrical care, gynecologic care, and transgendered people is such an important topic. I think it is not well understood and appreciated, I believe, amongst professionals. I think we're just beginning to sort of be comfortable with like the language, the terminology, and then the medical care part of it is a whole other aspect. And I think that there's important advocacy work that still needs to be done. That being said, there are lots of examples in the literature about uneven or inequitable access to care, whether that is due to the fact that people access the care but then don't get the care that they need because the healthcare professionals are not educated enough in the particular issues, both social and medical, that pertain to these individuals. I'm not aware of specific mortality reports in Canada. There are some reports of healthcare outcomes that are adverse, and I think I tried to touch on one of those examples in my literature. But if you just look at mortality statistics within Canada, we don't collect that information very well, and then we don't collect the characteristics or demographics such as race, gender diversity, etc. within that data. So so we still have a data drought, and so we're talking about our patients, but I think it would be interesting to know what that data looked like. We have pretty robust data from the United States that tells us about increased mortality in various equity-seeking groups. And so I think it's just a matter of time before we start to uncover those answers. This is not really a complete answer, I do apologize, but I think it just reflects the level at which our knowledge stands at this time. But I do thank you for the question.
Perfect. Next, we have more of a comment from Christina. She says, excellent work co-leading the PCMCH guideline. It was so refreshing to see many of the psychosocial aspects included. Thank
you for that comment, Christina. It was I guess a labor of love. I don't know if that's the right term, but I appreciate that comment, and we took that to heart and felt very strongly as we were going through the process and preparing those guidelines.
Perfect. Next from Brooke, given your specialization in bariatric pregnancy and the need for equity inclusion with this population when it comes to policy development and care in a labor and delivery unit, can you speak to how we can advocate for this population to ensure inclusion and several tips you may have in working with this population?
So thank you so much for that question. I'm sorry, I didn't can't recall the name of the person who asked it.
It's from Brooke.
Thank you, Brooke. Thank you for asking that question. So perhaps maybe I'll come back and I can if you want, I could give a talk about that specifically. It is an area of my clinical interest and research and education. Through the wonderful collaboration of one of our other, one of my colleagues, one of our clinical nurse specialists, Susan Guest, we've developed a number of manuscripts and papers, as well as care plans and protocols to look specifically at this issue of care for people with obesity on labor and delivery. So part of it's procedural, educating the team, making sure, you know, you have the right equipment and the right sized blood pressure cuffs and gowns to keep people comfortable. But it's a little bit more than that. It's about getting a whole organization, a whole team to understand the components of that care. And I guess the goal would be that a person who might have obesity could come through the unit and feel that the wheelchairs fit them, that the beds are suited to them, that the equipment and the team are all prepared in such a way to provide the care seamlessly without them necessarily noticing it. And so I do believe that through protocols, through developing protocols and educating the team, that you can improve the quality of care and actually reduce the stigma around obesity. You know, we've talked a lot about different groups seeking equity, and we don't often talk about people who have obesity as being in one of those groups, but they face incredibly high rates of discrimination in our society, particularly if they are women, and particularly in healthcare settings. So it is a topic that is near and dear to my heart. And so what I would say is that educating the team, you know, in obstetrical care, that includes the ultrasound, you know, the Dopp tones that we do in the clinics. Sometimes it's extremely hard to auscultate a heart rate of the fetus in the first trimester in a person with obesity. And then if you send them for an ultrasound, the ultrasound unit that would be perhaps providing that care would need to have sensitivity over not expressing frustration when the visibility is difficult, or when it's not really possible to see the structures that need to be seen. In our unit, where we have quite a large population of people with obesity, because it's a part of our practice at our hospital, I think that people who provide the ultrasound care are now tuned into that. But if it's something you encounter once in a while, I think it can be a real challenge for the providers, and also being mindful that all providers who are doing ultrasound or perhaps trying to help move or mobilize patients have potential for personal risk and personal injury, given ergonomics and things like that. So the educational part and creating of protocols to sort of take the guesswork out of different care steps is really really important. I think is helpful. I've also given some lectures and spoken about just directly the issue of weight bias and stigma in our society and in healthcare. Just getting the word out there, getting people to kind of get more familiar, more comfortable with maybe not using the word fat, but you know, using the word perhaps obesity, not referring to people as, you know, an obese person, but saying it's a person with obesity, just changing the dynamic of how we use our language, and to try to make that a little bit less stigmatizing. So a bigger discussion, but perhaps for another time, but I really do appreciate that question.
Awesome, thank you so much. Next one is from an anonymous attendee. So from earlier slide, you showed a change in the ratio of men and women in OB-GYN as a physician, and was interested in hearing the nursing perspective. As a male nursing student, several of my professors have been surprised with my interest, and I have not encountered any males or heard any nurse speak of a male nurse in OB, NICU, or L&D.
Right. So thank you, Anonymous, for that question, for those comments, and for the question. And I will admit that I'm not privy to similar kind of demographic data from the nursing world. So I'm hoping perhaps somebody in the audience or one of our leaders may be able to help out a little bit. But I do think that from an MD perspective, I'm concerned. I'm concerned if any group is at risk of being excluded from our profession, because again, if you want to have the best care, the best innovation, the best advances in the field, you need that diversity, that plurality of voices. And so that means both in terms of sex, in terms of gender identity, in terms of racial backgrounds and various other features or attributes or affinities. And I believe that male nurses are quite underrepresented in our community, and I don't know what the experience is like in the places where all of you are working who are attending this conference tonight. But I suspect that it is there must be some challenges being part of a group that that are underrepresented within the profession. And I'd be interested to hear also how the, I guess, the RNAO or how your colleagues strategize to try to support members of that community. For our male medical learners, it is a challenge. We're trying to come up with strategies to get around the issues of patients not wanting male providers to be involved with their care. It's a tricky question because you need to also, of course, balance patient autonomy and the wishes of the wishes of the individual in terms of how their care is to be delivered. But on the other hand, we can't systematically discriminate against male providers. And so finding that balance and looking for strategies to better educate our patients, set expectations about the care, and to create a supportive and collegial environment for our male learners when sometimes they are rejected from certain care groups. I'm sorry that I can't address that more fully for you, but I don't know if Emily or if anyone in the group can shed some light or give some perspective there.
Yeah, for sure. So one of the comments from Andrea Fulton, who was saying that she has several male nurses on her NICU unit, as well as male physician assistant and male NP. Obviously, even just at Sinai in the NICU, there are a handful of male nurses and other healthcare providers as well. I don't particularly know of their experiences, if they have been turned down. I believe so that it is less of a issue in the NICU versus in the L&D or a postpartum unit. I currently do have a few male nursing students in my clinical group in a postpartum unit. So far, we haven't had any issues of refusing care or anything, as I think most patients are just thankful, especially in that period. And understanding that, these are our future nurses and frontline workers, and it's important for them to gain the experience in all fields of nursing during their nursing school practicums. So hopefully that helps answer your question a little bit. I wish we could have some more, male insight on this matter, but if you are interested, I can definitely connect you with some of the male nurses in the NICU that I know. If that's something you'd like, if you can message me privately or email the Maternal Child Nurses Interest Group on Facebook, and I can respond to you there as well.
Thank you, Anonymous, for that question, and thank you, Andrea, for providing some context for us. And I think I'll do a literature search on that a little bit later, because I'm sure that it must be reported out there. It would be interesting to see what has been reported so far. So yeah, that's something I'll reflect on afterwards.
For our next question, also from another anonymous attendee, they say, as a nursing student, I would love to learn more about equity, particularly in regards to the LGBTQ2S+ populations. What resources would you recommend I consult to gain more information about this topic?
So thank you, Anonymous, for that question. I think that there are some great resources. I may have to forward maybe Emily the link to one of them. The resource I'm referring to is actually a module or a series of modules that help with education for providers and how they interact with patients who identify with diverse genders, gender identity. In terms of us as professionals, I think that the people who will be leading efforts to improve increase awareness about equity, diversity, inclusion are the ones I think tasked with trying to address this issue. I think it's important to have all of these voices at the table as we try to improve our professional environment. I will try to forward that resource to you. I'm sorry, I'm just blanking on the website at the moment, but I think that it has other links for both professionals and for patients in addressing this issue, the issues related to LGBTQS healthcare professionals. I would also say that there are some of the U.S. medical universities or medical faculties have incredible resources. I'm thinking in particular of Harvard Medical School. I think that they have an excellent website that provides great resources related to gender issues. So I can also send that link perhaps to Emily, if that's okay. And if you would be willing to share that with the community, that would be great.
Yeah, for sure, I can do that. We also have a few links that were sent in the chat. So Lori linked a website to some nursing data. So it's www.cihi.ca/en/nursing-in-Canada-2019. So there's some data and stats on there if anyone's interested. Also, in terms of this question towards the LGBTQ community, Beth shared a link, which is learn.rainbowhealthontario.ca. So I'm sure if you're interested, there's a lot of resources on there.
Yeah, that's the link I was referring to. It's a fantastic set of modules and resources. So thank you for sharing that. That was, sorry, I missed the name, but Beth. So Beth and Lori, I think both provided resources. Thank you for doing that.
Perfect. Okay, so on to our next question from Lindsay again. What do you think the priority of students should be when it comes to advocating for equity, diversity, inclusion in their faculty, i.e. nursing faculty? Should we focus on policy, curriculum, or admissions, etc.?
Wow. So all of the above. Great question. Thank you for asking that question. I think that policy, organizational changes, I think I mentioned in my talk, is really important to create sustainable change. And when an organization looks at its processes within its professional ranks, it includes recruitment, it includes application process, it includes retention of people from different types of backgrounds. And that also means that those individuals may need additional support or mentorship to ensure their success. I think that our leaders, so certainly within the medical profession, I think that our leaders would benefit from additional education in equity, diversity, and inclusion. So that's more than just having courses, let's say, in implicit bias, but really understanding at a fundamental level, what does equity mean when you embed it in the structure of an organization? If you are a student, you likely have leaders such as your dean or academic leaders who I'm certain must be tasked with addressing these issues. And if not, you should ask for it and start the change. Certainly at the University of Toronto Faculty of Medicine, there are a number of medical student organizations that have started that are student driven, that are looking at issues of equity. So whether it's racial or gender identity, there are a number of these groups, and they have been instrumental in affecting change at the systemic level. And the faculty will consult these groups as new programs and initiatives are implemented, particularly like the examples I gave you in terms of Indigenous health curriculum and the Black health curriculum. So you can change things. You're important because you are part of the future professional group of professionals. So your voice is important and should be heard. I thank you for asking that question.
Wonderful. Just to add on, I am in my master's program at U of T as well. So something that we're doing at the Graduate Nurses Student Society is that we've opened up a scholarship award specifically for Black and Indigenous students. And this is mostly to encourage more Black and Indigenous nursing leadership positions. And as the financial concerns is mostly the biggest hurdle in obtaining graduate education, this is something we have put in place just this year for the upcoming admission session, to increase that volume of students that, applying.
It's wonderful. Great initiative.
I believe that is all so far for questions. Is there any last minute comments or concerns? Please raise your hand or post it in the Q&A below. Okay. If not, thank you everyone so much for attending and being engaging in the conversation, asking questions. I think everything that was asked is so important for all of us to understand and take back to our workplace so we can spread the good messages and lessons learned here today. Thank you, Dr. Maxwell. Do you have any last comments to go?
Just that I really appreciate the opportunity and interest to discuss this and to come to this group. Again, I'm very honored to have had this invitation and this opportunity to talk to you. I'm encouraged and heartened to see how these issues are really taking flight, and people are really starting to talk about them, and they're not necessarily easy things to talk about all the time as well. So it takes courage to have the conversations. It takes courage to ask those questions. So thank you for speaking up, and for those of you who are listening thoughtfully. I hope that this was helpful and hopeful, and looking forward to taking next steps as professional colleagues working together.
Thank you so much. We have a last minute comment from Christina. She said, thank you so much. I would love to hear the presentation on obesity if we can invite Dr. Maxwell back. So we will definitely plan that for the future. I see that there's an interest, and
sure. Delighted
if you're
to
willing, Dr. Maxwell, to come back and present for us, we'd love to have you anytime, of course. So this concludes our webinar today. Please stay in touch via Facebook, Instagram, as well as on the RNAO website. If you haven't joined the Maternal Child Nurses Interest Group already, please consider being a member and spreading the word. Our next presentation webinar will be in February on the 13th as well, I believe, and it will cover intellectual disability perinatal experiences. Yeah, that will be our next seminar. Thank you so much. Have a good night, everyone, and take care. Stay safe.
Stay safe, everyone. Take care. Bye-bye.